Oh, will it start now? Yeah, I think it's started now. So what I'll do is I'll just restart. Everyone should be able to hear now. Yeah, there we go. Okay. So I'll just repeat kind of the first bit I was talking about. Yeah, I'll wait for you guys to refresh the page. Okay, cool. So, hello everybody. My name is Waleed. I'm one of the Foundation Year 2 doctors at UHB, currently working at Heartlands Hospital in cardiology. And today I'm going to be giving a talk on cardiac emergencies. So that kind of follows on from respiratory emergencies, which was one of the talks I gave a couple of weeks ago. And in the feedback, there were a couple of people who asked for a cardiology-based session in a similar way. So that's what we're doing today. So similar to the first session, we'll kind of talk through it in a scenario-based approach, looking at common acute things that you'll see from a cardiology standpoint. So we won't be covering kind of the long-term management of chronic conditions and some of the more niche cardiology stuff, which can be covered in a different talk if you guys would be interested. And with that, I think we'll get started. So we'll cover some aspects of the UK MLA curriculum. And the actual 4 things that I was sent through from the curriculum were covering acute coronary syndromes, so including MIs, cardiac failure and arrhythmias, and then cardiac arrest as well. Now, cardiac arrest goes more into that ALS algorithm side of things, so we'll briefly touch upon that, but that is kind of a session within itself, so that can be covered in more detail at a different time. There's other cardiac emergencies in terms of stuff you'll see on the front door, such as hypertensive emergencies and what to look out for, and then stuff like tamponade as well, which is a bit rarer, but it has kind of a very much exam-based, exam-focused bunch of findings that you should be aware of. So with that, I think we're ready to get started with the first scenario. So let's go. The first one is a 76-year-old male who's presenting with chest pain on a background of a previous STEMI. I'll give you guys about 30 seconds or so to read through the history and the A2E assessment. And then if you could just pop in the chat what you guys think would be relevant further investigations. These sessions are meant to be kind of as interactive as possible, so do feel free to pop any questions at any time in the chat, as well as answers. And each one's based on kind of an A2E approach as well, because that's a kind of a prerequisite regardless of whether it's a cardiac emergency or a respiratory emergency or whatever. So with that brief, we've got usually as transient chest pain on exertion, now as having severe chest pain at rest as well, and GTN improved it. What would be some kind of further investigations that are crucial to do in this scenario? Just pop it in the chat. Yep, we would do an ECG definitely. Often that's just kind of a part of C regardless, but yes, an ECG. Anything else? Yep, we would do a chest X-ray in the scenario as well. What else would help us kind of differentiate between the potential diagnoses at this stage? Okay, yep, you've done kind of a physical examination as part of E, as well as in terms of the circulation as well, and it's just a gentleman who's a bit sweaty, but otherwise there's not anything too overt on physical examination. Yeah, exactly. So chest pain bloods as well. So troponins, as well as one that you've not mentioned, their D-dimers are important in this scenario as well, because it can be secondary to something like a PE that'd give you chest pain, although albeit not usually relieved by GTN, but it's something you got to rule out. So yeah, that's all right. I've Of course, there's more investigations that you do, but the two that I've kind of highlighted are on the next screen here. So you do an ECG, and I've just shown you kind of the lateral leads on this one. And then also you've got the blood test results. So now trying to piece it all together, we've got, can anyone tell me what this ECG is showing? And we can kind of infer that the other leads were normal in this scenario. Any abnormal, kind of just going through the ECG, is there anything abnormal about? Yeah, exactly. So we've got some T-wave inversions in V5 and V6, and AVL as well, actually. And also, I don't think we've got any ST depression in this scenario, not that I can see. But yeah, we've got T-wave inversions, which are kind of a non-specific change, but can indicate ischemia. And then the troponins are negative. It could also be a sign of previous ischemia, exactly, yeah. Alongside Q waves and things like that. Now, so we've got that, right? We've not got any kind of ST elevation or anything like that. But we've also got the bloods with the troponins being negative. So going back to the history now, we've got troponins negative, and you've got severe central chest pain, which has been present at rest and improving on GTN. What would that indicate to yourselves in terms of what the diagnosis could be in this scenario? Yeah, so unstable angina. So in terms of ACSs, unstable angina is an ACS. And the reason why it occurs is because of critical vesicle stenosis. But the kind of differentiating factor from the others is the fact that it's not causing an infarction. I probably should have asked this question before switching to the slide, but the main difference between stable angina and unstable angina, and why unstable angina is, an acute coronary syndrome and therefore a cardiac emergency, is because it's occurring at rest. And therefore it's treated similarly to an NSTEMI. So we've kind of gone through, by looking through the history, the key differences between NSTEMI, STEMI, and unstable angina. But I've made a table as well, which I think outlines it well. So starting off with the mechanism of what actually is going on. Unstable angina is that critical vessel stenosis, which is causing transient ischemia to the endocardium, but it's not going through the cardiac layers, and it's not actually infarcting the tissue there either. NSTEMIs come almost like a step above, where you've got that stenosis, and you might have partial plaque rupture. However, it's not extending throughout the layers of that cardiac muscle. So it's still endocardial, but it's infarcting the tissue there. And then a STEMI is transmural, so it's going not only in the endocardium, but also in the myocardium and epicardium. And therefore, that's why you get ST elevation on the ECG. ECGs can be normal in NSTEMI and in unstable angina, but you may also see T-wave inversions, which is what we were seeing in the ECG earlier. You may also see ST depression. The way to differentiate then between an NSTEMI and unstable angina is, as we did earlier, by looking at the cardiac markers such as troponins. So you'd expect raised dynamic troponins in an NSTEMI, dynamic meaning increasing by over 20% when you do serial troponin measurements. In a STEMI, you don't need a raised trop for the diagnosis. You would expect a raised troponin. However, if you see that ST elevation with the history matching that presentation as well, then you treat it. You're not going to wait for a troponin to see whether it is a STEMI or not. So in terms of management of ACS, moving to that, there are kind of hallmarks for what you do regardless of what the exact diagnosis is, and then there are specific points for each. So before I kind of talk about that a bit, could anyone tell me what would be something that would be done for any of these patients, whether it's a STEMI, NSTEMI, or unstable angina, in terms of initial management? Yep. And what does MONA stand for? I've seen, I think it's Mona, Monarch, Monac. There's a couple of these abbreviations, but Mona meaning, well, I'll say morphine, oxygen, nitrates, and then aspirin. Yep. And then, yeah, actually DAPT in terms of dual antiplatelet therapy. Um, so that is something that you'd give to pretty much any patient that comes through the front door with any of these presentations. I think morphine is more for its vasodilatory effect. But we'll move on to the next slide. So, we'll go to the management in a second, but this is your classic ECG for a STEMI. And can anyone tell me what territory you'd expect this STEMI to be? And perhaps what vessel that you'd expect this to be affecting? Yep, it's an inferior STEMI. So therefore RCA. It can also be circumflex. You kind of have to look at the AVL and look for the reciprocal change to tell you. But in this scenario, yes, it is an RCA lesion in this scenario. So moving on to the management. So ACS management in terms of the front door is 300 mg aspirin, loading dose as soon as possible with adequate pain relief, such with GTN. Um, with STEMI patients, it's a lot more hyperacute in terms of prompt reperfusion therapy. You wouldn't expect them to be kind of on the clerking list for the medics in ED. They tend to kind of go straight to cardiology through mechanisms at each trust. And then the actual management is dependent on the time of symptom onset as well as the time of first medical contact. So PCI, primary percutaneous coronary intervention, is the preferred strategy, which is basically angiography with a stent if required. And that is the kind of gold standard almost. But if it's not possible, then fibrinolysis with something like tenexplase can be done for reperfusion therapy. Now, it's important to note as well that kind of in the real world, if you do try fibrinolysis and it doesn't work in terms of reperfusion therapy, then the next step would be for PCI. And then afterwards, patients usually on DAPT, depending on kind of trust guidelines, but usually, especially including the trust that I'm currently working at, it's DAPT for 12 months. And we'll look at the STEMI flowchart in a second, which will kind of show you how they decide which second antiplatelet to choose, as well as cardiac rehab and then secondary prevention. So statins, usually a high dose secondary prevention statin, so like 80 milligrams of atorvastatin, as well as consideration for ACE inhibitors and beta blockers if they are indicated. In patients with an NSTEMI or unstable angina, you give antithrombin therapy, so something like fondaparinux, and then mortality risk needs to be considered prior to kind of deciding what the next step is. Can someone tell me perhaps a scoring tool that we use for gauging mortality risk in these patients? I guess it's a good MCQ. What would you use to gauge mortality risk in non-ST elevation ACSs? Okay. That might be a different test. I've not used TIMI before, um, but we use the GRACE score. So GRACE scoring, and that looks at kind of factors in the medical background of the patient um, to decide whether they require angiography within 72 hours. It's listed as 96 hours in other places, but I think nice. Is the second antiplatelet given with aspirin as part of MONA? So aspirin is given at a baseline, and then the second antiplatelet in most places is indicated, but it's not a must in the guidelines. Um, but in our trust currently, we do tend to load patients with aspirin and then either prasugrel or ticagrelor or prior to intervention. But in terms of the actual guidelines that I could find, it was aspirins that must be given, and then it's trust guidelines from there. So this is a nice flow chart which kind of sums up pretty much everything we were just talking about. I wanted to condense it down a bit for the previous slide, but this kind of tells you what the conditions are for angiography. So it's 12 hours of symptom onset, as well as if it can be delivered in 120 minutes from door to table. And then if not, then the fibrinolysis. This also then mentions stuff about kind of using drug-eluting stents and things like that. So it's important to just have a read of, just to kind of know it, especially for finals and things like that. And it also kind of helps you with your understanding of how these things are actually managed in the real world. So moving on to our second scenario. Any questions about the first before we move on? Just have a quick look at time. We're doing well. Okay, let's move on to our second scenario then. So we've got a patient who's come in with shortness of breath. He's got a background of type 2 diabetes and then previous ischemic heart disease. And he's got progressively worsening shortness of breath, which has now got a lot worse. And he's unable to lie down. And that's your A2E assessment, because as with any patient, you want to approach with that A2E assessment. What investigations would you be looking to do in this scenario? We've got a couple more this time around, I think. Chest ultrasound. Okay. Yeah. So we'd get a chest X-ray, I think, in the first instance. I'm confused about the implications. The 120 window. All right. I'm just gonna have a quick read of this question. What if they present within 10 hours of symptoms starting? Does that extend 120 minutes? I don't think it necessarily is that stringent usually. I think this is more kind of in the ambulances as well, so I wouldn't be too certain. But I think if you can get a patient to table in 120 minutes, then the kind of onset of symptoms, as long as it's there or thereabouts, PCI is the gold standard, so you'd kind of favour doing PCI. In terms of exactly what the guidelines would say in this scenario, I wouldn't be too certain, unfortunately. Maybe Zenil might be able to help me with that one. But kind of in the real world, I think in that scenario, you would take them to cath lab if you could. So moving back to this scenario, we've got we do a chest X-ray in the first instance. just to have a look at exactly what we're looking for, and then afterwards we can see if something like that's indicated. Is there any other investigations they'd be looking to do in this scenario? I've just realized as well, sorry, a chest ultrasound, you're meaning echo, right? Yeah, chest ultrasound is the same as echo. So yeah, a TTE, yes, we would be thinking about doing a TTE in this scenario for sure. Chest x-ray, ECG, echo, yeah. Anything with the bloods that might decide for us whether an echo chest ultrasound would be indicated in this scenario. Yeah. So BMP would be a good marker to start with. And then if you've got that raised BMP, then you would move on to a chest ultrasound echo. And then a chest x-ray as well. I think that's most of them, if not all of them. And yeah, just because there was low O2 as well, you'd probably end up doing an ABG in this scenario as well. And this is what you see. So we've got a chest x-ray here, and then we've got a BMP of 12,093, with the normal BNP being kind of below 400, I believe. ECG shows normal sinus, an echo showing left ventricular failure, and then the ABG showing that. My next question was going to be, what can we see on that chest x-ray? Yeah. Anything else? I appreciate the picture isn't the best, but there's a couple of signs associated with what this is, which is congestive cardiac failure. A couple of signs on X-ray, and I think a couple of them can be appreciated even with. I'm just going to get a bit closer, just to have a look. Yeah, a couple of them can be appreciated definitely on here. Anything else anyone's seen? Yeah. So alveolar edema, definitely. You can see kind of these fluffy patches. Curly B lines, it's difficult to tell looking at this, but right in the corner there, perhaps. And then cardiomegaly is quite prominent on this one. So cardiomegaly being defined as over 50% of that cardiothoracic ratio. A cardiothoracic ratio of over 50%. So moving on to the next slide, which will show us kind of the signs laid out. There we are, yeah. So you can, to be honest, even now with it circled, the curly B lines aren't the most prominent on this, but they are what you expect is kind of these horizontal lines, fine lines extending to the edge. So that are the curly B lines, which is basically interstitial edema. Then you've also got these blunted costophrenic angles, which are bilateral pleural effusions. And then the upper lobe vessel enlargement as well. So these are all signs associated with congestive cardiac failure. And my next question would be, in terms of management of a patient in this scenario, so going back to kind of the clinical brief that we had, what would be the management in this scenario? Or what would you be focusing on? Yeah, definitely. Yeah, exactly. You guys have covered kind of the main bases there. So in this scenario, the first thing you'd actually get the patient to do is sit up, just because lying down is going to make it a lot worse. But after sitting the patient up, definitely give oxygen therapy. And then the mainstay of treatment, as Ahmed has mentioned, is diuresis. and optimization of the CCF control. So you're going to be managing the fluid overload. When you have someone with decompensated heart failure, especially in a situation where, as you can see, we've got pulmonary edema and then as well as bilateral pitting edema to the shins. So we've got this biventricular failure, um, which is altogether congestive heart failure. So that'll be an admission, usually, if you've got an oxygen requirement as well. So you're going to give oxygen therapy, you're going to diurese the patient, usually with loop diuretics, and then just a couple of things for you to have down in your mind for plans that you'll be making for patients that you see with decompensated heart failure at the front door, whether you're clocking in ED, is you want to be monitoring their U's and E's, especially when you're giving them loop diuretics. You want to be checking their weights daily to see that they are losing the fluid and restricting fluids, input-output monitoring as well. We're not going to cover kind of the long-term management in terms of cardiac devices and things like that, but that can often be where poorly controlled heart failure can lead. But what you would also do in the acute setting is make sure that they are on good CCF control. So medications like ACE inhibitors and ARBs, beta blockers, SGLT2 inhibitors such as dapagliflozin or empagliflozin, and then MRAs or aldosterone antagonists such as spironolactone or eplerenone are proven to be beneficial in terms of providing mortality benefit in patients with heart failure, and with MRAs it's specifically only in heart failure with a reduced ejection fraction, which this patient had. And then, quick question, don't we need to assess the class? Yes, so definitely. So that's, again, talking more about the chronic management of heart failure. You would be looking at the NYHA classification and tailoring the therapy according to that. But in the acute setting, again, it's just kind of just looking at the medication and making sure that's all fine. And then in terms of long-term heart failure management therapy, that should be considered for sure. A question that is often asked, I think, in SBAs and things like that is which of these medications provide mortality benefit? And it's just important to know that loop diuretics such as furosemide are providing symptomatic benefit rather than mortality benefit. Okay. Excellent. So next case, we'll go to a case of palpitations. I won't read it out to you guys. You can just have a quick read of it and let me know what the most relevant investigation, if there is only one that you could do, would be in this scenario. Yep, definitely. An ECG and an echo. So let's start with the ECG. First of all, you would get an echo definitely in this scenario as well, but this is what our ECG is showing. So how would you define this? pop an answer in the chat. What is this ECG showing? Yep, it's irregularly irregular, and it's we've got no P waves that you can comfortably make out, and therefore this is atrial fibrillation. So in terms of atrial fibrillation, can someone tell me a bit more about some causes of atrial fibrillation, or kind of what you'd be looking out for in a history if you see someone who's presented with a seemingly first presentation of atrial fibrillation? What could be potential causes that could drive AF? Yep, pretty much. Yep, previous ischemia for sure, definitely. So in her history, the previous ischemia is kind of the telltale sign there. But Ahmed's completely right. Pretty much anything that stresses the heart can lead to AF. However, there's a nice mnemonic, Pirates, which tells you perhaps the more common causes of atrial fibrillation. So atrial fibrillation, especially with a fast ventricular response, which was seen in that previous ECG, is something that you'll see at the front door. And fast AF can be a cardiac emergency in terms of the management, but causes can kind of vary from stuff like PE, but then also a rheumatic heart, so kind of listening for murmurs, with regards to the mitral valve, and then previous MI, previous coronary artery disease, previous ischemia in general is kind of a major one that you need to be aware of. But it can also be iatrogenic, and many cases of atrial fibrillation, there's not really any clear root cause, and it can start off as PAF or a paroxysmal atrial fibrillation, but that always tends to kind of lead to permanent AF in the long run. So, in terms of management, in the acute scenario, what's stuff you would be looking out for to try to decide what your management's going to be? What's kind of the first step of your stratification of this patient in terms of they come in with AF, they've got fast AF as well. What's the next thing you're kind of looking at to decide how we're going to go down managing this patient? Okay, so yeah, kind of scoring mechanisms are used for stuff like deciding for anticoagulation in AF, such as like the CHA2DS2-VASc score and kind of orbit scoring and things like that, which we will get to as well because that's important, even in the acute scenario. But first of all, when you've got a patient who's coming with AF, especially a fast AF, an AF with fast ventricular response, that's a tachyarrhythmia. So we need to go down the algorithm, the ALS algorithm for tachyarrhythmias. So the first thing that we'd be looking for actually is whether the patient is hemodynamically stable, because that would change your management in the acute setting. So in this scenario, the patient's blood pressure is 109/66. They have got a background of hypertension, so that is low for them, definitely. But they are still hemodynamically stable in the fact that, the blood pressure is still above 90/60. The heart rate isn't, above kind of 150, 160, where you'd be worried about hemodynamic instability. And the patient, his GCS-15 is talking to you. So because we don't have hemodynamic instability, you wouldn't be going down the left side of this ALS algorithm, which would be actually to give kind of a consider DC cardioversion, and then also giving amiodarone IV, and then giving synchronized DC shock up to 3 times before an amiodarone infusion. So that's when you've got adverse features such as shock, syncope, or acute ischemia accompanying it, or acute heart failure accompanying it. Because we don't have any of those, then we look into deciding things like rate control versus rhythm control. So, patients presenting acutely without significant hemodynamic instability or any of the adverse features that I just mentioned would be managed using rate or rhythm control. The guidelines do vary, but the NICE guidelines, as well as my current trust guidelines, do mention that if there is a definite onset in the last 48 hours, so if you're in hospital and you've got clear evidence that there was normal tinnitus before and they've gone into AF, then rhythm control can be offered, which can be either DC cardioversion or pharmacological rhythm control, such as flecainide or amiodarone. However, in our history, we've got the lady having, I think it was an Apple Watch or something, which told her that the 3 days ago is when she noticed the abnormal heart rhythm, which is why she wouldn't kind of qualify for that. And even still, it's important to note that rhythm control tends to be on a basis where you need to look at the patient holistically, seeing whether they would be a candidate for rhythm control. So patients with less comorbidities, younger patients would be more considered for rhythm control due to the risk of adverse effects associated with it. In most patients, especially in my kind of experience, is that you will find that the AF onset is uncertain, or they may be unsuitable for rhythm control for a variety of reasons, and then rate control is given. And rate control is done through beta blockers, rate-limiting calcium channel blockers, so diltiazem or verapamil, and then also digoxin. And that's kind of depending on whether they have heart failure or not as well. If they have heart failure, then there's a kind of different branch on that flow chart with stuff like digoxin, whereas you'd be looking at rate-limiting calcium channel blockers and beta blockers as your first line otherwise. But as someone mentioned earlier in the chat, that's kind of managing the acute symptoms. You're going to try to get that rate down. So, for example, in this lady who had the heart rate of 132, AF with fast ventricular response, giving a stat dose of bisoprolol or something like that, and then monitoring that, seeing whether that adequately brings the rate down. If they stay in persistent AF, then you would be looking at things like adding digoxin potentially. Remember, another thing that they like to put in questions is to never give beta blockers and verapamil together because it can cause complete heart block. So that's something to note as well. But what else should be considered in this scenario? I think someone alluded to it a bit earlier with the scoring system. But what does atrial fibrillation tend to predispose you to? And it's a relatively well-known complication of AF. Stroke, or in fact any kind of thromboembolism. So stroke being the main one though. And therefore we use scoring systems such as the CHADS VASC score, which will help you decide whether a patient should be anticoagulated. I think it's good to know roughly what the different domains of the CHADS VASC score are, because it does make sense, and also it's something that you could be asked about. And it's just good to know for kind of your clinical work in the future as well. Basically, if the CHADS VASC score is above 2, So 2 or above, that's when you would be indicated to give or at least consider um, long-term anticoagulation. If it is 1, then it's just a consider, and 0 would be that it wouldn't be indicated in that scenario. With patients who come in with AF, a lot of them are elderly, and therefore you've got to balance the risk of anticoagulating a patient alongside their actual bleeding risk as well. Um, and scores like Orbit and Has Bled can help you with seeing what the bleeding risk would be if you were to start a patient on anticoagulation for specifically for AF. In terms of the anticoagulation of choice, it matters a lot on kind of trust by trust. Our trust uses edoxaban, and NOACs in general are kind of preferred in AF. But again, that would be down to your trust guidelines. So that's kind of looking at tachyarrhythmias such as AF, and this flow sheet is directly from kind of the ALS algorithm, and it shows you, in terms of tachyarrhythmias, just in general, the rule of thumb is if there's adverse features, you should be looking to um, give a synchronized DC shock. And if it's not, then you look at the ECG, whether you've got a narrow complex tachycardia or a broad complex tachycardia, with broad complex tachycardias being more, I don't want to use the word serious because it's not necessarily the right way of going about it, but broad complex tachycardia is usually being the one where you should be looking for senior help. Whereas with narrow complex tachycardias, that AF is, a narrow complex tachycardia if it's regular, and then if it's regular, you're looking at an SVT, and that's your adenosine management, which I think this is the old. Just having a look at it now, I think that might be the old guideline because I think it's now 6, 12. I might just need to have a look into that actually because I don't think it's 6, 12, 12 anymore. If anyone who has seen it recently could just let me know. But that management may have changed for SVT. So that's your tachycardia management in terms of the ALS algorithm. I didn't want to really go into too much about the ALS algorithm just because, as I said, it's its own kind of thing. But it's important to know your bradycardia algorithm as well. Again, with life-threatening signs, you need to give the atropine, and there's in your actual clinical work, you'll be asking for help at this point, definitely. After kind of giving the atropine. But that's your bradycardia algorithm. And then the only other thing I kind of wanted to note on, I can see that we've got about 5-10 minutes left. The only other thing I wanted to note on was just a couple of rhythms. So you've got your degrees of heart block, just kind of knowing them. This is the top one is. Can anyone actually tell me what the top one is in terms of heart block? Yep, that's first degree heart block. So what you've got is just a prolonged PR interval over 200 milliseconds, but there's no kind of other changes noted. So that's your first degree heart block. And then beneath that, you've got, well, actually, again, can someone let me know? I think I put them in order, which gives it kind of away. But if anyone can tell me what type of heart block that is. Yeah, so that's Mobitz 1, second degree heart block. So what you've got here is a progressively lengthening PR interval until a missed beat and then it resets. Both of these can be caused by multiple things. The first degree heart block can be a normal variant in younger people, and they don't factor into your bradycardia algorithm. But as you can see in that bradycardia algorithm, you do have Mobitz 2 AV block, um, and then also complete heart block, which I'll show you now. And these are the ones that you need to be kind of aware of. Uh, in terms of Mobitz 2 heart block, you've got a consistent um, rate between the P's, but you've got the missed QRSs. Um, and that can be in a ratio as well. You can have Mobitz 1 or Mobitz 2 in a ratio. Um, but that P to P length is constant, whereas in the previous one, it isn't. It's kind of lengthening, then you drop a beat. And then in complete heart block, you've got complete dissociation between your P waves and your QRSs. I saw this for the first time kind of clinically a couple of weeks ago. And it was interesting. In that lady, it was a congenital thing, and she had to eventually get permanent pacemaker. Get a permanent pacemaker. But these two are the ones that kind of feed into your bradycardia ALS algorithm, so they're the ones you should be aware of because they pose a risk of asystole alongside ventricular pause of 3 seconds as well, which is basically where you don't have a QRS complex for 3 seconds. Now, other cardiac emergencies which weren't part of the curriculum that I was sent, but I thought were important to mention, definitely, are things like cardiac tamponade, which is basically fluid or blood in that pericardial sac. It's usually in the vignette or in the brief or in the clinical scenario, you would have evidence of some sort of chest trauma beforehand. Often it's a stabbing, or evidence of kind of a reason for a pericardial effusion in the first place. And you'd expect to see, perhaps not clinically as obviously, but you would have a raised JVP, muffled heart sounds, and then hypotension, which are Beck's triad on examination, and then a big globular heart on that chest x-ray, because you can imagine that pericardial sac is filled with fluid, which would make it a lot bigger. And then the management for that is pericardiocentesis, which is basically just putting in a needle and aspirating that fluid and removing it to stop it compressing the heart, basically. Something that you will see incredibly commonly is hypertensive urgency versus hypertensive emergency. And that is something that you'll, regardless of whether you're doing a medical job, a cardio job, even if you're doing a surgical job covering wards, you will see this. You'll be bleeped about this, definitely. And it's really important to kind of know how to approach these scenarios, because you will, especially as an F1, get a bleep. A patient's blood pressure is 198 over 115. Can you come review? And in those scenarios, it's important to know what you're looking for. It's to assess for kind of end organ damage, so changes in vision, any headaches, worrying about stuff like hemorrhages and things like that. And then also bloods, looking at the U's and E's, looking at the renal function, looking at whether they're passing urine, and then deciding whether they have got any signs of end organ damage, which would be a hypertensive emergency, in which case you'd manage it with an IV beta blocker, as per kind of the guidelines you have. Often it's something like an IV labetalol. And if there is no end organ damage, but you've got a patient with a blood pressure of 205 over 120, then you'd give oral antihypertensives, which are more potent and fast acting, something like a modified release nifedipine, which is what our guideline at our trust is. And then finally, the last thing I wanted to mention was that ALS algorithm for cardiac arrests, remembering your 4 H's and your 4 T's. So just to end off, if you guys can just shout out any of the 4 H's or 4 T's, let's see whether we can name them all before we call it a day. So the 4 H's and 4 T's being things that you need to factor in when you're concerned about, not concerned about, when you've got a patient who has arrested, that may be a potential cause. So yes, hypoxia, definitely a very common one. Anyone else? Yep. Or metabolites in general, but hypokalemia, hyperkalemia as well, hypovolemia. So that can be due to kind of bleeding as well as kind of septic. And then hypothermia. Yep. So that's your 4 H's and your 4 T's. One of them is on the slide currently. Yep, thrombosis, definitely. Toxins, yep. Tamponade, and then finally, it'd be tension, exactly. Tension pneumothorax as well. So that's your 4 H's and 4 T's. And I've been in a couple of kind of cardiac arrest scenarios, and it genuinely is a case of the cardiac arrest team lead will stand there and audibly talk about the 4 H's and 4 T's. And that's part of your ALS training and algorithm. So it is in clinical practice as well. At every cardiac arrest, you'll have the team lead saying, okay, guys, let's consider the 4 H's and 4 T's, going through them and seeing what may be causing it, and therefore what we can do about correcting that if it is a reversible cause. Well, these are reversible causes. Okay, so that's about everything. I think we're good for time as well. In fact, hit it right on the head. So that's perfect. I think, yep, go ahead. Quick question. For cardiac arrest, once you restore it, you find the cause, right? Are we talking about getting ROSC in terms of restoring it? So like return of circulation. Once you restore it, you find the cause. Yeah, so once you get ROSC, of course, we would continue to, yes. So you would be looking for kind of what caused it in that scenario, yeah. During an arrest, you've got people doing compressions, you've got people, and then once you've got ROSC, you can have a look at things like previous gases, looking for signs of this and then correcting that. I didn't catch that. Try again. But you would still consider it during the arrest as well. For example, if the patient, is profoundly hypothermic when you get there, or is bleeding out, then trying to stop that bleeding as well whilst the resuscitation is going on would be something you'd do as well. So it's something you're looking for during the arrest call as well as in the immediate management afterwards if you do get ROSC, yes. Okay. Any other questions or anything like that? I'll just pop by a minute. If you could also please fill in the feedback form as well with anything else. It's more to consider. Okay, I understand the question now. Yeah, so it's more to consider it as being the likely cause, not necessarily looking for it, but you would, if you've got a patient who's um, having an MI and then they arrest, then you would know that the cause was likely thrombotic. Um, so it's more just trying to figure out what the cause was, rather than we wouldn't be able to we would take them to table, but I meant it in that sense rather than looking for signs of thrombosis. It's more looking through the clinical presentation and history, because you'll have a lot of people part of the arrest call, and just finding out why this has occurred. Cool. Thank you very much, guys. Just pop in the feedback form, and then we didn't cover things like infective endocarditis or more um, other cardiac topics. So that is kind of for another session. So if that's something you'd be interested in as well, just pop that in the forms, and we'll see whether we can make that happen. Okay. Excellent. Thank you very much, guys.